Hi, my name is Aparicio, and I am the cornea and contact lens resident at the Illinois College of Optometry. Today, we will be going over a case presentation for patient ND. He is a 25-year-old African American male who presented to the clinic complaining of blur at distance and near without any glasses. He reported previously wearing glasses about 4 years ago, but stated that the glasses didn't do much to improve his vision. The patient had also had a secondary complaint of ocular irritation of both eyes due to having eyelashes rubbing against the front part of his eyes. He reported the onset being after he was diagnosed with Stevens-Johnson syndrome in 2007, secondary to phenytoin use. Of note, his vision was 20/80 in the right eye and 2200 in the left. He then pinholed to 20/60 in the right eye and 20/80 in the left, so there was definitely room for improvement as far as vision goes. Some slit lamp findings of note included trichiasis and thickening of the eyelid margins for both eyes. Diffuse conjunctival injection and scarring of the palpebral conjunctiva in both eyes was also noted. The corneas of both eyes had peripheral neovascularization 360, with the right eye being worse than the left, and inferior corneal steepening worse in the left eye compared to the right eye. Due to the corneal findings on slit lamp, we decided to run a pentacam on the patient. A cone can be appreciated centrally with posterior corneal steepening greater than anterior corneal steepening. Similarly, on the left eye, you can also see that cone centrally with the posterior cornea being steeper than the anterior cornea. Due to the slit lamp findings and the corneal tomography, the patient was diagnosed with keratoconus coinciding with his already diagnosed Stevens-Johnson syndrome. When considering our treatment approach, we took into account his need for better vision while also keeping in mind the ocular surface disease, which included dry eye disease and ocular irritation from the misdirected eyelashes. We ultimately elected to proceed with a scleral lens fit, as scleral lenses would provide a smooth refractive surface to improve the vision, and a large diameter lens would also be able to vault the cornea, allowing the tissue to be continuously bathed in sterile saline. In addition, the scleral lens will allow for protection of the cornea from any misdirected eyelashes. With scleral lenses on, the patient's vision improved to 20/40 for the right eye and 20/40 for the left eye. After a month and a half of full-time wear, the patient reported symptomatic relief of his ocular irritation, and the corneal neovascularization of both eyes had improved. Aside from the improved vision and comfort, the patient expressed that a sense of normalcy had been restored in his life. He said, "These lenses have been life-changing. I can't imagine life without them now. Not only do I see better, but they also help me feel more confident. I used to hate the idea of having to deal with these large lenses in order to see better, but now the only thing I hate is knowing that my vision won't be as good when I take them off at the end of the day." We as optometrists have the ability to improve vision and comfort with scleral lenses. Knowing that we can drastically improve a patient's quality of life inspires me to keep learning about new ways that we can make a difference.